Hello, my name is Daniel Kamenstein, and today I'm going to be talking to you about ultrasound in the evaluation of schistosomiasis. I'd like to begin by thanking Joachim Richter, who's probably the world's foremost expert in this topic. Unfortunately, Joachim wasn't available to give this lecture, but had kindly allowed me to use some of his slides and images. He was the main editor and probably the foremost guide to the use of ultrasound for the evaluation of schisto. And we're going to be talking about some of the things found in this guide because I think it's a good framework for the different findings that we see by ultrasound in both urogenital and intestinal schistosomiasis. Now, just as a refresher, schisto is broken up into two main forms, as I said before, intestinal forms, which have four main species, and then urogenital forms as well. Now, within the intestinal forms, really, geography has a lot to do with their distribution, and as we see, most of the burden of disease is really within Africa, where Mancini and Hematobium play a predominant role. Japonicum is mostly found within Asia itself, and we're really going to focus mostly on talking about these forms as we move forward. As a quick refresher, just to remind everyone about the actual disease itself and the life cycle, because it plays an important role in how we use ultrasound in evaluation. The adult worms live either in the mesenteric veins or in the venous plexus around the bladder, and they lay tons of eggs. Just as a quick refresher about the life cycle of schistosomiasis, the adult worms live in the mesenteric veins or around the venous plexus of the bladder, and they lay tons of eggs. These eggs then go through a snail intermediary until they form cercaria again. The cercaria then penetrate the skin, migrate through the circulation, and then paired adult worms again repeat this cycle. Now, the real problem and pathology that comes in humans is that these eggs sometimes don't make it out of the bladder or out of the intestines and can actually get stuck somewhere either in the bladder wall, the intestinal wall, or get washed back up through the portal circulation. Traditionally, it was by most of the eggs either get excreted through the bladder or in the intestine, and traditionally this is how infection was measured, either by doing urinary filtration or stool smears and detecting the eggs in these cases. Now, obviously, this is fairly time-consuming and not the most pleasant of tasks. It also really doesn't tell you about the disease itself. While egg burden, either in the urine or stool, can give you a good idea of how infected someone is, the eggs that are excreted don't cause the problems. It's actually the eggs that get stuck either in the liver, in the intestines, or in the bladder that cause the pathology. And that's because there's fibrosis that occurs around these eggs, as you see in this picture here. And either if they get stuck within the intestinal wall or if they get washed back up through the mesenteric circulation into the portal vein and then deposited into the liver itself and fibrose there, this is really what causes problems. And it's these long-term complications of schisto is what ultrasound is best at detecting. So we're going to break this lecture up into two main types of ultrasound. We're going to talk about ultrasounding for both urogenital and for intestinal schistosomiasis. Now, when you talk about hematobium, we're looking at eggs that mostly get stuck on their way through the bladder wall, and these can cause local polyps or stony patches here and ultimately lead to complications and, if severe enough, cancer of the bladder itself. There's actually an entire grading system of how to grade the severity of urinary schistosomiasis. In the end, there's actually a score that is come up with, and we're not really going to talk too much about the score itself, but we're going to use the framework of this document to kind of talk about the complications that we see. And there are really three main types of complications we're going to look for when ultrasounding for urinary schistosomiasis. We're going to look at the bladder, we're going to look at the kidneys themselves for the degree and severity of hydro, and then we're going to look for any possible dilation in the ureter. So the first is the bladder, and there's actually a progression of effects to the bladder. You can see small bladder irregularities which appear just like this. So the rest of this bladder is fairly normal in appearance, and here's a small irregularity. You can then go on and see entire thickening of the bladder wall itself, which you see right here. Normally the bladder wall should be quite thin, as in this picture, and here you can see marked thickening of the bladder wall. You can see masses, you can see polyps here, and you can even see large irregular masses here, which are quite concerning for possible cancer. This image is not actually of a schistosomiasis patient, but it does illustrate how marked these bladder tumors can appear by ultrasound in some cases. This is an ultrasound image of someone with urinary schistosomiasis, and what you can see here is a very irregular, thickened bladder wall, some areas of polyps as well. And you can see kind of how distinct this bladder appears in cases like this where someone has been chronically infected for quite some time. As mentioned, there is a way to score this, as well as there is a way to score the appearance of the kidneys and ureters. And we're really going to focus a little bit about talking about the kidneys themselves, because this is probably the thing that you will see most often, and that's some dilation within the kidneys or hydronephrosis. Just to refresh your memory, this is a normal appearing kidney, so we can see here an intact renal pelvis here, very bright, and then the cortex kind of dark around it. Does not appear at all thinned, and actually appears darker than the liver next to it. You can see this is a kidney with mild hydronephrosis, so now you're seeing some dilation here, some black in the center here, which normally shouldn't be there, but it's still a normal appearing cortex. This is a finding of moderate hydronephrosis, so we're seeing a little bit more dilation here, and a little thinning of that cortex in this case. Finally, severe hydronephrosis, where we're actually getting marked dilation, as well as starting to see some thinning here, all the way to the point where you see almost complete obliteration of the kidney. The fascia of the kidney you can still kind of make out surrounding it here, but the rest of the kidney is almost completely obscured by the large amount of hydronephrosis which you see here. The ureters also can be dilated. In this case, this is a proximal ureter that's dilated. It's kind of hard to pick out without the arrow, but here's that proximal ureter that's dilated, and we can see the kidney here. This is a distal ureter that's dilated, in this case right here. This is the bladder here. We're seeing, in this case, this is actually not schisto, this is a kidney stone or a ureteral stone that's sitting here, causing the ureter to become dilated, and we see the iliac vessels right next to it here. In some cases, it may be difficult to tell a dilated ureter from the iliac vessels running next to it. Putting color flow on might help you in these cases. Now, it's important to not only know about these ultrasound findings, but realize how this plays a role in patient care. And there are actually some studies that show that probably the ultrasound pathology and the severity of that pathology by ultrasound correlates pretty well with egg output. And so in cases like this, by ultrasounding a single individual, we could estimate how severely infected they are likely to be, but also by screening entire populations, you can pretty quickly by ultrasound get a sense of the community at large and how infected it is. So just as a refresher, the three things we're going to be looking at are the bladder, looking for signs of irregularities or thickening the bladder wall, and then evaluating the kidney, looking for hydronephrosis, and looking for any signs of the ureter being dilated. As I mentioned before, intestinal schistosomiasis has 4 main species. We're mostly going to be focusing on 2 of them, Mansoni and Japonicum. And while they do have some different ultrasound characteristics, we're really going to focus on mostly their similarities. Now, because it is intestinal form, you can find intestinal findings by ultrasound manifesting as some wall thickening or polyps. But because the intestines are sometimes hard to ultrasound, these findings can be subtle, and there's certainly quite a few pathologies that can mimic this. Just as an example, this is normal. So this is a normal intestinal tract here. We see some fluid-filled loops of bowel, normal wall thickness, and they're compressing here between the psoas muscle, which is sitting right here, and the abdominal wall musculature. This is a abnormally dilated loop of bowel. We can actually see some to and fro peristalsis of the intestinal contents going on here, some free fluid around it, and actually some thickening of that bowel wall itself. This is not a patient with schistosomiasis, and this just goes to emphasize that you can see abnormal intestinal findings in quite a few pathologies. This is actually not polyp, but just part of the normal intestinal wall that is not normally seen unless the intestine becomes fluid-filled. Mostly what we're going to be looking for is some findings of the eggs as they are deposited around the portal circulation. So, as I said before, those eggs often get washed back through the mesenteric vein into the portal vein, and those eggs get deposited around the portal circulation. And when they do, they fibrose, and they cause what's called this pipe stem fibrosis, which is named after these old-fashioned pipes. And these are really kind of the fibrosis that occurs around that portal vein itself. So as we evaluate hepatosplenic schistosomiasis, we're going to be looking for 3 main things. We're going to be looking at the periportal fibrosis, we're going to be looking at the liver appearance itself, and then evaluating portal blood flow. There is an entire grading system for the appearance of the liver and the periportal fibrosis, and this goes all the way from A to E. I'm not going to spend a lot of time talking about each of these in detail because it kind of goes beyond the focus of this lecture, but just as a reminder that you can usually correlate severity as you move from A all the way to E. Now that's for Mansoni. Japonicum actually has a slightly different appearance, either these narrow mesh-like appearance or a wider mesh-like appearance in this case. And this is what it looks like by ultrasound. It actually leads to one of my favorite ultrasound images, which I call, or I think of as the psychedelic liver or the underwater liver here, where you can see this mesh-like appearance. Kind of almost makes the liver look like it's underwater. Now, when we're talking about Mansoni, which is really going to be the focus of the remainder of this lecture, partially because it has the most information behind it, and also because it is certainly the most frequent. With Mansoni, what we're really looking for is fibrosis, again, around the portal circulation. So here's a portal vein here with normal appearance. And we can see a portal vein with some periportal fibrosis. We also, as I said before, going to look at the portal vein itself and look at the size of it, look for any signs of dilation because of portal hypertension. Here, as a refresher, is the anatomy that we're going to be looking at. So we're going to look at here's the IVC here. Here's the aorta. There's the splenic vein coming into the portal circulation. We see the portal vein here. This is celiac axis right over there. This is SMA here. And you can see quickly how, again, portal vein here, all of these vascular structures can make things quite confusing, which is why reviewing your vascular anatomy and reviewing your liver anatomy when evaluating any tropical disease as it affects the liver is going to be pretty important. So just as, again, as a refresher, celiac axis, aorta, IVC here, portal vein here, splenic vein right there, and we're going to see the SMA sitting up right up here, aorta, SMA, and then we see the IVC coming off there. We're also going to be thinking about how the liver looks itself. So this is a normal appearing liver in terms of size and echo texture. we can see that there is actually a little bit of So here we can see a liver with periportal fibrosis. As opposed to our previous image, we see a portal vein here, but quite a marked amount of fibrosis around that portal circulation itself. So these very bright areas around the portal circulation, around the portal vein and around multiple branches. If we go back and look at that previous image, what we saw was portal vein here, but a fairly homogeneous appearance to the liver. So the liver itself looks fairly homogeneous. You don't see any bright areas within the liver, as opposed to this image here where you see lots of bright images. And this is a sign of periportal fibrosis. It's fairly characteristic. There are other diseases that can cause similar appearances, namely the appearance of the liver with HIV. But in the appropriate patient, this is There are other disease processes that can give a similar appearance, but in a patient who you suspect as having schistosomiasis in an endemic area, this can be a fairly convincing finding. Here's another image which we see here. You can see that very bright areas of periportal fibrosis really jump out at you compared to the rest of the liver. And when you're evaluating the liver, don't forget that you really need to evaluate in both horizontal, oblique, and longitudinal axis, so you make sure you're evaluating the entire liver. And again, as with the urinary schistosomiasis, there actually is a scoring system here based on the pattern of the fibrosis we see. So just to remind you, there are several patterns. We mostly looked at patterns B and C in these cases, but you can certainly have multiple different types of patterns that show up by ultrasound. The other thing to evaluate is the portal vein itself. And the portal vein anatomy is a little bit tricky, but just to remind you again, the mesenteric vein comes in, meets up with the portal vein and the splenic vein, and that forms the portal vein that then branches into the right and left portal vein. So by ultrasound, what this looks like is the portal vein, which is here, and we looked at that before. The portal vein is here next to the IVC. And we can actually trace that portal vein into the right side of the liver here. So the liver, it branches. So the portal vein, the portal vein branches and actually turns into the right portal vein, which has two branches that come off there. And then the left portal vein, which is actually up here. And we'll see that coming off. There's the right again, right portal vein here and branching there, and the left portal vein up here. And so you can actually follow that vein around. And you can look for the size of the vein. So normally the portal vein should be fairly narrow in size. Usually what we say is less than 13 millimeters in diameter in the portal vein. And obviously the walls, as we talked about before, should not be thick. We also want to make sure that we look at the liver itself and just mark how big it is, but also look for some signs of ascites. In this case, we can see a cirrhotic liver with a fair amount of nodularity to it as well, and some surrounding ascites. So not only are we looking at signs of fibrosis, but we're also looking at the portal vein and the liver in general, and that's going to give us the rest of this scoring system here. Portal hypertension is probably one of the more difficult things to talk about, and certainly because liver anatomy is somewhat tricky, it's probably one of the harder things to see. For our purposes, we're really going to break this down into looking for four main things, and these are a little bit easier to find than some of the other subtler things. One would be just looking for a larger than normal diameter of the portal vein. As I mentioned before, 13 millimeters is frequently cited as the number for the maximum size of the portal vein. We're going to look for signs of esophageal varices, or more specifically, a recannulized periumbilical vein. The umbilical vein closes at birth, but with high portal pressures, it can reopen, and it looks fairly tortuous, as we'll see. And then looking for presence of ascites, which can often indicate some portal hypertension, and looking for some reversal of flow within the portal vein itself. So we're going to run through each of these. This is a same video clip you've seen multiple times before with a normal size portal vein. And this is opposed to a markedly dilated portal vein, which you see in this image here. So this is the portal vein here. It is enormous, very dilated, hard to miss because the IVC and the aorta, which are actually sitting back down here, are very small in comparison to this large dilated portal vein here. And this is the same patient here where we looked at the dilated portal vein. And one of the consequences of this high portal hypertension is a recannulated periumbilical vein. So this is a vein, as I said, that closes at birth, which can open up with high portal pressures. And if we put Doppler flow on it, we can see high Doppler flow on it. And that is an indication that we're looking at high pressures within the portal system that are now pushing open these veins and marking the way for varices to form. Ascites is a little bit more straightforward, and certainly we talked about this when evaluating for free fluid in the FAST exam lectures. But one of the things that can be a little bit harder to realize is that free fluid around the liver itself can sometimes be confused with free fluid around the lung. So here's a normal liver with no ascites. Here we're looking at diaphragm, and we're looking at some fluid that's sitting actually in and around this right lung here. So this is a pleural effusion as opposed to ascites, which sits around the liver itself. The final component of portal hypertension that's a little bit more difficult to grasp is the actual measuring flow within the portal vein, and not necessarily the speed of flow, but just direction. So normally the mesenteric vein here meets up with the splenic vein here and flows into the liver, and that's called hepatopedal flow, so flows into the liver in this case. And that's measured by ultrasound as either Doppler flow, which goes towards the ultrasound probe. So here's the ultrasound probe face here, and this is going to be Doppler flow that's going towards the probe. Here's our scale on this side, and what we see here is red flow. Red to yellow flow is flow that's moving towards the probe, and then blue flow is flow that's away from the probe. And so we can see this is blood normally flowing into the liver, and we can actually see a little Doppler gate here with pulse wave Doppler, and we're also measuring venous flow going towards the liver. Now, with a lot of periportal fibrosis and these high portal pressures, that actually starts to push blood out of the liver, and that's called hepatofugal flow, when portal vein blood flow reverses, and that actually leads to, again, some varices dilation. It can lead to enlarged spleen, and also what leads to pushing some fluid out of the vasculature and into the abdominal cavity, causing ascites. And that's fairly easy to pick up by ultrasound as well. With Doppler flow here, we can see Doppler flow away from the probe. So here's the probe face in this case here, and this is flow away from the probe itself. So that all leads again to a final score. And it's fairly complex, but what I want you to take away from that is, just as with urinary schistosomiasis, that score actually can, to some extent, predict pathology. So there have been findings and studies that suggest that the higher the score is, both in terms of portal vein, periportal fibrosis and portal vein diameter, probably the higher risk people are for GI bleeding. And so by combining all of these different things, we can, again, screen for pathology within a patient and probably do some community screening as a whole. That's going to conclude this lecture on the evaluation of schistosomiasis by ultrasound. Thank you for your attention, and I hope that you guys got something out of this lecture.